This is a recorded lecture for Chapter 25, Fluid, Electrolyte, and Acid-Base Balance in the Anatomy and Physiology series of the classes, be the 230 Anatomy and Physiology. We look at the body water content. We see that infants, 73% or more of their water is really, they're 73% or more water. They have low body fat, really low bone mass, so the bulk of their body mass, or their density, if you will, is based in water. In adult males, that drops to about 60%, and in adult females, about 50% of their body is really made up of water. They have a higher fat content, they have less skeletal muscle mass than do males, and so that's where it comes to. The water water content declines to about 45% in old age as the cells begin to age, and the overall water content in each cell begins to becomes abnormal. The fluid compartments, when we talk about the fluid compartments, we're really talking about the total body water in all of the body, and that adds up to about 40 liters of fluid, so we're totally made up about 40 liters. There's intracellular fluid, and that's the 2/3 of the 25 liters are in the cells. The extracellular fluid, where 1/3 of the 15 liters, is 1/3 of 15 liters are outside of the cell. The plasma makes up about 3 liters of that. Interstitial fluid, that's fluid within all the tissue spaces, makes up about 12 liters. And the other extracellular fluid is really within the lymph and the cerebral spinal fluid, the humors, vitreous and aqueous humors of the eye, the synovial fluids of the joints, the serous fluids between the serous membranes and the pulmonary and the peritoneal and the pericardial sacs, and then we have gastrointestinal secretions that aid in the process of food breakdown, digestion, and absorption. We look at total body water. You see that 40%, or there's 40 liters, 60% of the body weight, and then you see here the intracellular fluid is really 25 liters, or 40% of that, and that extracellular fluid is 15 liters, or 20%. So the 60%, 40 is usually intracellular, 20% is usually extracellular, and interstitial fluid makes up 12 liters of that. This is a way to kind of keep track of that. We talk about the composition of body fluids. Water is the universal solvent. And because it can absorb and all sorts of things, if you will, dissolve in it, and so that makes it the universal solvent. The body, there are several kinds of solutes those are elements that are dissolved in the water proper, which can be electrolytes or non-electrolytes. The non-electrolytes are mostly organic, and they don't dissociate necessarily in water. For instance, glucose and lipids, creatinine, and urea. As opposed to electrolytes, which clearly dissociate into ions in the water, like, for instance, inorganic salts, all acids and bases, and some proteins. The most abundant and the most numerous solutes are the electrolytes. They have greater osmotic power than non-electrolytes, and so they contribute to the fluid shifts of the body, the fluid moving from the extracellular space to intracellular space from the cardiovascular system into the tissue system. And they determine the chemical and physical reactions of fluids based on the electrolytes. So these electrolytes are elements that can carry charges. Electrolytes are concentration really expressed in milliequivalents per liter, or MEQ over L. And it's really a measure of the number of electrical charges per liter of a solution. For instance, the milliequivalent per liter equals the ion concentration, that's milligrams per liter, times the number of electrical charges, and the atomic weight of an ion, milligrams over millimoles, is on one ion. So that kind of gives you a feel for what's going on. For a single charged ion, like in sodium, you have 1 milliequivalent equals 1 milliosmol. For bivalent ions like calcium, which has a +2, there's a 1 milliequivalent equals 1/2 mole, if you will, or osmolality. Each fluid compartment has a distinctive pattern of electrolytes, and so you have extracellular fluid, which is all similar except for the higher protein content in the plasma. The major cation of the extracellular area is really sodium, and the major anion is chloride. And so sodium having a positive charge, one positive charge, and chloride having a negative charge. In the intracellular fluid, which really has a low amount of sodium and chloride, the major cation is really potassium. And the major anion is HPO4. And you get a feel, we'll talk a lot more about that as we get along, and we're talking about the beta-2. The extracellular and intracellular fluids, the proteins, phospholipids, cholesterol, and natural fats make up the bulk of dissolved solutes, 90% in plasma, 6% in intracellular fluid, 90% or 6% in interstitial fluid, and 97% in intercellular fluid. And this really goes through. This chart is really a good chart for looking at the different solutes that are located in the fluids throughout the body. What you're really seeing here is the sodium, the amount of total sodium across the board. You see in the blood plasma, lots of sodium in the blood plasma, and you get kind of a nice feel for what we're talking about as we look at concentrations of things across the board. We talk about fluid movement among compartments. That's really regulated by osmotic and hydrostatic pressures. Water moves freely by osmosis. You remember that osmosis is fluid moving from an area of low concentration to an area of high concentration. And so the osmolalities of all body fluids are almost always equal. It kind of equals things out. There's the two-way osmotic flow is substantial, and ion fluxes require active transport of channels, or channels, if you will, down the line. There's a change in the solute concentrations of any the change in solute concentration of any compartment leads to a net water flow. So what we're really saying here is that the movement of fluid is really osmotically directed and with hydrostatic pressures within the tissue and with the cardiovascular system. Water moves freely by the osmotic process, which is a passive process. Osmolalities of all body fluids are almost always equal just because of the equalization of that osmosis. There's a two-way osmotic flow, which has a very substantial effect, and the ion fluxes require active transporter channels. And a change in that solute concentration in any compartment leads to flow of fluid to equal that solute change. And this really follows that, as you can see the lungs and what they do with O2 and CO2. You see the gastrointestinal tract as it affects nutrients and water ions. And then you're seeing kidneys. And they affect water ions also, but also nitrogenous waste, and how that fluid, how those solutes, if you will, can change the movement of fluid from one place to another. Water balance and extracellular fluid osmolality. The water intake equals water output, hopefully, and that should be about 2,500 mils a day, or roughly 2.5 liters. Water intake is a total of all the beverages you drink, water, Cokes, whatever, the amount of water that's in food, and then the metabolic water. We'll talk about that. Water output is really urine. The insensible water loss to the skin, the lungs through respiration and perspiration, as well as what we defecate, and the fluid that's in our stool. And so the average intake of water per day is at 250 or 2,500 mils. You can see that 10% of that is metabolism, 750% is in foods, and 1,500 mils is really in beverages. As far as the average output, you can see that 100 mils is really in feces, 200 mils is in sweat, 700 mils is insensible losses via the skin and the lungs, and then 1,500 mils a day is really via the urinary output. We talk about regulation of water intake. The thirst mechanism is the driving force for how we bring in water, and that's an imperfect mechanism, actually. Strangely enough, the thirst mechanism doesn't always work as well as it should, and there are some reasons for that. The hypothalamic thirst center has osmoreceptors, which are stimulated by decreased plasma osmolality, and so there's a change 2 to 3%, and then there's a 2 to 3%. The angiotensin II, or the baroreceptor input, if you have a dry mouth, and there's a substantial decrease in blood volume or pressure. Now, this is where it's kind of imperfect, because sometimes you can have a large hemorrhage, and the body's feeling of thirst does not come on until way after the person is in hemorrhagic shock. Drinking water creates an inhibition of the thirst center most of the time, and there's inhibitory feedback signals which include the relief of the dry mouth, and then there's the activation of the stomach and intestinal stretch receptors which tell us, yes, we drank some water and we're full. This goes through that process, if you will. You can see the plasma osmolality, there's saliva, and the osmolar receptors in the hypothalamus, and the dry mouth, they work on that hypothalamic thirst center, as do the plasma volume, decreased blood pressure, granular cells in the kidney, the renin-angiotensin mechanism, and of course the angiotensin II. They affect all that thirst center. There's a sensation of thirst where a person takes a drink. The water moistens the mouth, the throat stretches, the stomach and intestine. The water is absorbed from the GI tract, and the plasma osmolality is now improved, and so there's this feedback mechanism that continues until everything has been sort of resolved. When you look at obligatory water losses, we get those from several locations. We have insensible water loss from our lungs when we breathe in and out, and our skin as we perspire. We have water losses within our feces as we defecate. And there's a minimal daily sensible loss of about 500 mils in urine to excrete waste. So the body water and sodium content are regulated in tandem by mechanisms that maintain the cardiovascular function and the blood pressure. It's interesting, and we'll talk more about that, the sodium in a bit. The regulation water output is if we look at the influence of ADH, antidiuretic hormone. Water absorption in the collecting ducts is proportional to the ADH release. So if there's a decreased amount of ADH, so the antidiuretic hormone prevents us from urinating, if you will, or decreases the fluid in the urine. The fluid is dilute because there's nothing to hold it back, so there's more water going out. There's a decreased amount of water volume in the body, but an increased amount of water output to the kidneys. On the other hand, if the ADH is high, antidiuretic hormone is high, that means not much water is getting out to the kidneys, and so the urine is concentrated in the kidneys, and the body retains more fluid. Now, the hypothalamic osmolar receptors actually do trigger and inhibit the ADH release. So the hypothalamic osmolar receptors trigger whether there's ADH released or not. And the other factors that can trigger ADH release via large changes in the blood volume or pressure are like fever, sweating, vomiting, or diarrhea, blood loss, and traumatic burns. But sometimes when these things happen, this mechanism does not kick in until way later. You look at the osmolality, sodium concentration in plasma, that stimulates several things to happen. The plasma volume, the blood pressure is 10 to 15%. It inhibits, you see that process that comes down. If there's a negative, you see the initial loop, the osmolar receptors in the hypothalamus cause the posterior pituitary, antidiuretic hormone is released, collecting ducts to tubules, there's water reabsorption, and water is brought back into the body. Some disorders of water balance include dehydration, and there's a negative fluid balance where extracellular fluid water loss can happen due to hemorrhage, severe burns, prolonged vomiting or diarrhea, profuse sweating, water deprivation, or diuretic abuse, where somebody takes a lot of diuretics, which causes an excess loss of water. The signs and symptoms include thirst, very dry, flushed skin, and oliguria, which means very little water or very little urine output. This could lead to weight loss, fever, mental confusion because of loss of water, hypovolemic shock, and the loss of those electrolytes, which are imperative in the function of almost everything in our body. The mechanism of dehydration, there's an excessive loss of water from the extracellular fluid. Extracellular osmotic pressure rises, and so the cells lose the water to the intracellular area to the extracellular area based on osmosis, and the cells begin to shrink. We also can have hypotonic hydration. So cellular overhydration or water intoxication, where somebody takes in too much water. This occurs with renal insufficiency or a rapid excess of water ingestion. For instance, somebody tries to drink a lot of water. The extracellular fluid is diluted, causing hyponatremia, a low sodium in the blood. There's a net osmosis in the tissue cells. The cells begin to swell through osmosis. It causes some severe metabolic disturbances, which include nausea, vomiting, muscular cramping because of the dilution of sodium and potassium primarily. We have cerebral edema because it causes the fluid in the CSF to start to become more dilute, and it starts to swell, and so death can ensue. That happens when you look at the mechanisms of hypotonic hydration. There's an excessive amount of water enters the extracellular fluid. The extracellular fluid osmotic pressure falls, and so the fluid moves from the area of low concentration to area high concentration, and it fills the cells, and it can actually explode the cells given enough of an angle or enough of a incline between the osmolality of the intracellular fluid and the osmolality of extracellular fluid. We can also have edema, which is an atypical accumulation of intracellular fluid due to tissue swelling. That can be due to anything that increases flow of fluid out of the blood or hinders its return, like increased blood pressure and hypertension, increased capillary permeability, usually due to inflammatory-like chemicals. You can have incompetent venous valves where the blood never returns, or it's difficult for the blood to return to the heart, and they have varicose veins. You can have localized blood vessel blockage, which allows the blood not to move through the tissue. Congestive heart failure, where there's a pump failure and the water starts to the blood starts to back up. Hypertension, as we talked about before, and then increased blood volume as a sudden increase in blood volume. What happens with edema is there's a hindered fluid return occurs with an imbalance in the colloid osmotic pressures. In other words, the plasma proteins are diluted, and so the fluids fail to return to the venous ends of the capillary beds, and results from protein malnutrition, liver disease, or glomerulonephritis. So a hindered fluid return is caused by those colloid pressures. So if there's not a protein in the plasma to hold the fluid in, the fluids never return. They go out into the tissue. If you have blocked or surgically removed lymph vessels, this causes leaked proteins to accumulate in the interstitial fluid. There's an increased colloid pressure, osmotic pressure of the interstitial fluid, which draws fluid from the blood and causes edema to the area. This results in low blood pressure, and it certainly affects circulation, but it pulls all the fluid out of the circulation. You can have electrolyte balance. Electrolytes are salts, acids, and bases. Electrolyte balance refers only to salt balance, interestingly enough, even though salt balance can be affected by lots of things. Salts enter the body by ingestion and are lost via perspiration, feces, or urine output. There's importance of salts. They help control fluid movements. They have some level of excitability because they're electrolytically active. They are involved in the circulatory activity, and they can manage and they can control membrane permeability. If you remember, we looked at the muscular system, and we looked at the nervous system. You remember that membrane permeability was very dependent on the electrolyte permeability. That was very dependent on the electrolytes of sodium and calcium. We look at the central role of sodium. It's the most abundant cation in the extracellular fluid we said earlier. The sodium salts in the extracellular fluid contribute 280 milliosmoles of the total 300 milliosmoles of ECF solute concentration. Sodium leaks into cells, is pumped out again against its electrochemical gradient. Sodium content may change, but the extracellular fluid sodium concentration remains stable due to that osmotic process. If there's a change in plasma sodium levels, it affects the plasma volume, blood pressure, intracellular fluid, and the interstitial fluid volumes. In the kidneys, the renal acid-base control mechanisms are coupled to sodium ion transport. So sodium really manages our acid-base control, at least with what the kidneys do. Interestingly enough, we have no receptors in our body that monitor sodium levels directly. Sodium-water balance is linked to blood pressure and blood volume control mechanisms. So sodium management is an indirect process, not a direct process. We also have aldosterone, and it helps to manage the sodium reabsorption. 65% of sodium is reabsorbed in the proximal tubules within the glomerulus, or the glomerular system, or the nephron system. 25% is reclaimed in the loops of Henle. So we look at the nephron unit, there's a proximal tubule, a loop of Henle, and a distal tubule, and the sodium absorption is 65% of that in the proximal tubule, 25% is done in the loop of Henle. Aldosterone it really causes the active reabsorption of the remaining sodium, so water follows sodium if ADH is present. That's a really good thing to remember. Wherever sodium goes, water follows. Great thing to remember, great little mantra. There's also a renin-angiotensin mechanism, which is the main trigger for aldosterone release. The granular cells of the JGA secrete renin in response to the sympathetic nervous system stimulation, or a decreased filtrate osmolality, or a decreased stretch due to decreased blood pressure. All those can kick the renin-angiotensin mechanism in, which will trigger that aldosterone release. The renin catalyzes the production of angiotensin II, which prompts the aldosterone release from the adrenal cortex. And so aldosterone release is also triggered by elevated potassium levels in the extracellular fluid. And aldosterone brings about its effect slowly. So aldosterone really doesn't make the intracellular fluid and the interstitial fluid change abruptly. It takes hours to days for that to happen. And this takes you through that process we just talked about. The regulation of sodium balance can also be done by the atrial natriuretic hormone, and that's released by the atrial cells in response to the increased blood pressure or usually injury to the heart proper. It decreases the blood pressure and blood volume, and it makes sense. If the heart is having trouble doing its job, it wants to decrease its workload, and it does that by decreasing the blood pressure and decreasing the blood volume. It causes a reduction of ADH and the renin-aldosterone production. There's an increased secretion of water and sodium into the urine. Wherever sodium goes, water follows. And it promotes vasodilatation directly, and also by decreasing the production of angiotensin II. And again, takes you through all that same process we just talked about. There's some influence of other hormones, and for one is estrogens. Estrogens increase the sodium chloride or salt reabsorption like aldosterone. If water retention, there's also water retention during menstrual cycles and pregnancies, and progesterone, which decreases sodium reabsorption and blocks aldosterone. So these work against each other, and you see how as the cycle of estrogen and progesterone occurs through the menstrual cycle, you can see how that would affect water retention. It promotes sodium, and when progesterone is released, it promotes sodium and water loss, if you will. Glucocorticoids cause sodium reabsorption, and they promote edema. We also have baroreceptors in the cardiovascular system, and they alert the brain of increases in blood volume and pressure. The sympathetic nervous system impulses the sympathetic nervous system impulses tells of the kidneys decline, and the afferent arterioles dilate. The GFR increases, that's the filtration rate, the gross filtration rate, glomerular filtration rate, and the sodium and the water output increases. So these baroreceptors actually alert the brain of increased blood pressure or water volume or blood volume, which kicks all this in and causes an increased output. And again, you can see that process through this to that table. There's a regulation of potassium balance, and the importance of potassium is it affects the RMP in neurons, and that's the resting membrane potential, and muscle cells, especially cardiac muscle. Increased extracellular fluid, potassium, decreases the resting membrane potential, and so it affects depolarization and results in a reduced excitability of the cells. A decreased extracellular fluid, which is potassium, causes hyperpolarization and total non-responsiveness of the cells. So it has a lot to do with how that manages. The hydrogen shift in and out of the cells leads to corresponding shifts in potassium in the opposite direction to maintain that cation balance. And so it interferes with the activity of excitable cells. Now, potassium balance is controlled the cortical collecting ducts by changing the amount of potassium secreted into that filtrate in the urine filtrate. High potassium content of the extracellular fluid favors the principal cell secretion of sodium. When the sodium levels are low, there's a type A intercalated cells reabsorb some sodium left in the filtrate. So what happens is all what happens in the kidneys. As the potassium balance is controlled, the cortical collecting ducts of the kidneys by changing the amount of potassium secreted in the filtrate, which is the initial glomerular filtrate. The high potassium content of the extracellular fluid favors the principal cell secretion, if you will, of that same potassium. And when the potassium levels are low, the type A intercalated cells reabsorb some of the potassium left in the filtrate. So this all happens within the kidney proper. The influence of aldosterone is it stimulates potassium secretion and sodium reabsorption by the principal cells within the nephron units. Increased potassium in the adrenal cortex causes the release of aldosterone and potassium secretion. We talk about the regulation of calcium. Calcium in the extracellular fluid is important for neuromuscular excitability. We've talked about that before. It's important in the clotting cascade. It's important for the cell membrane permeability, and clearly it's involved in the secretory activities. Hypocalcemia causes increased excitability and muscle tetany, and so the muscles just kind of twitch or hold in place in spasm. Hypercalcemia inhibits neurons and muscle cells and may cause heart arrhythmias. So the calcium balance is controlled, remember, we talked about that before, by the parathyroid hormone and calcitonin. So we were talking about the endocrine system before. We said that PTH and calcitonin, PTH have the greatest effect, and calcitonin manage the calcium levels of the blood based on how we reabsorb calcium and phosphorus in and out of the bone matrix proper. PTH, the bones are the highest reservoir for calcium and phosphates. The PTH, parathyroid hormone, promotes an increase in calcium levels by targeting bones, kidneys, and small intestine, indirectly using vitamin D. The calcium reabsorption and phosphate excretion kind of go hand in hand. So we reabsorb the calcium out of the bones into the bloodstream, and the phosphate is then excreted through the urine. And this takes you through that process, and this is just a review, if you will, of what we've seen before. Normally, 75% of filtered phosphates are actively reabsorbed in the PCT. The PTH, parathyroid hormone, inhibits this by decreasing the total, if you will, the TM. The regulation of anions, chloride is the major anion in ECF. It helps maintain the osmotic pressure of blood, and 99% of chloride is reabsorbed under the normal pH conditions. When acidosis occur, fewer chloride ions are reabsorbed in the kidneys, and so they go out to the urine. Other anions have transport maxims, and our excess are excreted in the urine. So when acidosis occurs, we don't reabsorb as much of the chloride back into our system. We look at acid-base balance. The pH affects all functional proteins and biochemical reactions in the body. And we know that the normal pH of body fluids in arterial blood is 7.4. It's actually 7.2 to 7.4. Venous blood and interstitial fluid, pH is about 7.35. In intercellular fluid, that pH could be 7, which is more neutral. Alkalosis or alkalemia, the arterial blood pH would be greater than 7.45. In acidosis or acidemia, the arterial blood pH drops to below 7.35. Most hydrogen is produced by metabolism, so we talk about the acid-base balance. That's important to know. Phosphoric acid, from breakdown of the phosphorus-containing proteins in extracellular fluid, we get lactic acid, which produces that hydrogen ion, if you will, from the anaerobic respiration of glucose. Fatty acids are ketone bodies, so the fat metabolism can produce the hydrogen ion. And finally, hydrogen is liberated from CO2, converting back to bicarb in the blood. The concentration of hydrogen ions is regulated sequentially through chemical buffer systems that are rapid and provide that first line of defense. The brainstem respiratory centers act within 1 to 3 minutes, which is pretty fast. And the renal mechanisms are most potent, but they usually require hours to days to really do anything productive, if you will. And so it takes them a little time to really get to where they need to get to. as far as changing the acid-base balance of the pH. So the brainstem works quickly, the renal mechanism works slowly. Strong acids dissociate completely in water and can dramatically affect the pH. Weak acids dissociate partially in water and are efficient preventing any significant pH changes because they kind of work like, almost work like a buffer, if you will. Strong bases dissociate easily in water and quickly tie up hydrogen, and weak bases accept hydrogen more slowly. And so a good slide is the next one. A strong acid, such as hydrochloric acid, dissociates completely into hydrogen and chloride in the water, where a weak acid, such as H2CO3, does not completely dissociate, so you see fewer free hydrogen molecules floating around. The chemical buffer systems. A chemical buffer is a system of one or more compounds that acts to resist pH changes when a strong acid or a strong base is added to the system. You can have a bicarbonate buffer system, a phosphate buffer system, or a protein buffer system. A bicarbonate buffer system is a mixture of a weak acid, H2CO3, and salts of bicarb, and so you end up with sodium HCO3, which is a weak base. This helps buffer there are buffers of intercellular fluid and extracellular fluid, and the only important extracellular fluid buffer is really that bicarb one. Bicarbonate buffer system, if a strong acid is added, the HCO3 ties up to the hydrogen and forms H2CO3. Hydrochloric HCl plus NaHCO3 actually transfers or transmutes, if you will, into H2CO3 plus salt. pH decreases only slightly unless all available HCO3 alkaline reserve is used up. So the HCO3 concentration is closely regulated by the kidneys. So the kidneys regulate the bicarb, if you will, within the system. If a strong base is added, it causes the H2CO3 to dissociate, and it starts donating to free hydrogen to equalize things out. The hydrogen ties up the base, i.e. the OH minus, OH if you will, and so sodium, you see sodium OH plus H2CO3 ends up sodium bicarbonate H2O. The pH rises only slightly, and so H2CO3 supply is almost limitless from the CO2 released by respiration, and is subject, if you will, to respiratory controls. Now, the phosphate buffer system, the action is nearly identical to the bicarbonate buffer system. The components are sodium salts of dihydrogen phosphate, so H2PO4, which is a weak acid. Monohydrogen phosphate, HPO4, is a weak base. And so they effectively buffer in urine and intracellular fluid where phosphate concentrations are high. We have a protein buffer system, and so intracellular proteins are the most plentiful and powerful buffers, and plasma proteins are also important. Protein molecules are amphoteric, which means they can function as both a weak acid and a weak base, which gives them a lot of variability and a lot of flexibility. When the pH rises, organic acid or carboxyl groups release hydrogen. When the pH falls, the NH2 groups bind with hydrogen. Respiratory and renal systems act more slowly than chemical buffer systems that have more capacity than chemical buffer systems. So both the respiratory and renal systems manage their acid-base balance. They act more slowly than those chemical buffer systems, but they have a lot more capacity. They're slower, but they can move it much farther or absorb more of the base or acid. The respiratory system works by eliminating bicarb. A reversible equilibrium exists in the blood, where bicarb plus H2O translates into H2CO3, and that can change to H, a free hydrogen, and HCO3. During CO2 unloading, the reaction shifts to the left, and hydrogen is incorporated into H2O. During CO2 loading, the reaction shifts to the right, and hydrogen is buffered by proteins. Hypercapnia activates the medullary chemoreceptors. Hypercapnia means an excess of carbon dioxide. The rising blood hydrogen activates peripheral chemoreceptors, and so more CO2 is removed from the blood, and hydrogen concentration is reduced. Alkalosis depresses the respiratory center, and the respiratory rate and depth decrease. Hydrogen concentration increases. The respiratory system impairment causes acid-base imbalances, so hypoventilation causes respiratory acidosis. Hyperventilation causes respiratory alkalosis. We have chemical buffers which cannot eliminate excess acids or bases from the body. The lungs have to eliminate the volatile carbonic acid by eliminating CO2. Kidneys eliminate other fixed metabolic acids, phosphoric, uric, and lactic acids, and ketones, and they prevent metabolic acidosis. The lungs deal with respiratory acidosis, alkalosis, and the kidneys deal with metabolic acidosis, alkalosis. The renal mechanisms of acid-base balance, the most important renal mechanisms, are conserving or reabsorbing or generating new bicarb or excreting bicarb. The generating or reabsorbing one bicarb is the same as losing a hydrogen molecule, and so excreting one bicarb is the same as gaining one hydrogen. So this is a balancing act the body goes through. Renal regulation of acid-base balance depends on the secretion of hydrogen. Hydrogen secretion occurs to PCT and the collecting duct type A intercalated cells of the kidney. And so again, the hydrogen secretion occurs in the proximal convoluted tubule and the collecting duct type A intercalated cells. The hydrogen comes from H2CO3, which is produced in reaction catalyzed by carbonic anhydrase inside the cells. And to see the steps 1 and 2 of the following figure, you can kind of have a feel for what we're talking about. You see that CO2 combines with water with the tubule cell forming H2CO3. The H2CO3 is quickly split, forming hydrogen and bicarbonate ion. Hydrogen is secreted into filtrate, and for each hydrogen secreted, a bicarb enters the pretubular capillary blood either via symport or sodium or via antiport with chloride. The secreted hydrogen combines with bicarb in the filtrate, forming carbonic acid. Bicarb disappears from the filtrate at the same rate as bicarb HCO3, within the tubule cell, and enters the paratubular capillary blood. The HCO3 is formed in the filtrate, dissociates to release CO2 and water. The CO2 diffuses in the tubule cell where it triggers further hydrogen secretion. So you get kind of a feel for the steps that occur with the acid-base management. We talk about reabsorption of bicarb. Really, tubule cell luminal membranes are impermeable bicarb. So CO2 combines with water in the proximal convoluted tubule cells, forming H2CO3. H2CO3 dissociates where hydrogen is secreted, and HCO3 is reabsorbed into capillary blood. Secreted hydrogen unites with HCO3 to form that H2CO3 in the filtrate, which generates a CO2, which ultimately ends up with and generates carbon dioxide and water. So HCO3 disappears from the filtrate at the same rate that it enters the paratubular capillary blood. And this walks you through that same process, just as we talked about before, but in the opposite direction. We're talking about generating new bicarb ions. There's two mechanisms in the proximal convoluted tubule and type A intercalated cells. They generate new bicarb to be added to the alkaline reserve. Both involve renal excretion of acid via secretion and excretion of hydrogen and NH4. The excretion of buffered hydrogen, dietary hydrogen must be balanced by generating new bicarb. Most filtered HCO3 is used up before filtrate reaches the collecting duct. So it's just a way of what we have for excreting that buffered hydrogen. Intercalated cells actively secrete hydrogen in the urine, which is buffered by phosphates and excreted. The generated new bicarb moves into the interstitial space via the transport system and then moves passively into the peritubular capillary blood. This goes through that same process we just talked about, and I've gone through, but the new mechanism. Ammonium ion, if you will, excretion involves metabolism of glutamate in the proximal convoluted tubule cells. Each glutamine produces two NH4s and two new bicarbs. The bicarbs moves to the blood, and NH4 is excreted in the urine. And this takes you again to that same process. Bicarb ion secretion when the body is alkalotic, type B intercalated discs secrete the bicarb, reclaim the hydrogen, and cause the blood to become more acidic. The mechanism is the opposite of bicarbonate ion reabsorption process by type A intercalated cells. We're talking about ion secretion, bicarbonate ion secretion. Even during alkalosis, the nephrons and collecting ducts excrete fewer bicarbs than they conserve, so it's not a great system. The abnormalities of the acid-base balance, we can have respiratory acidosis or alkalosis, and metabolic acidosis and alkalosis. Remember, respiratory is a lung phenomenon, metabolic is a kidney phenomenon. Respiratory acidosis and alkalosis, the most important indicator of adequacy of respiratory function is PCO2, or carbon dioxide levels in the blood, and it's normally 30 to 45 millimeters of mercury. PCO2 above 45 millimeters of mercury is respiratory acidosis. It's the most common cause of acid-base imbalances, and it's due to a decrease in ventilation or gas exchange. And it's usually characterized by a falling blood pH, going to acidotic, and a rise in PCO2, which makes sense. Respiratory acidosis and alkalosis, PCO2 below 35 millimeters of mercury is respiratory alkalosis. It's a common result from hyperventilation due to stress or pain. Metabolic acidosis alkalosis, any pH imbalance is not caused by abnormal blood CO2 levels, is really metabolic. And it's indicated by abnormal bicarb levels. The causes for metabolic acidosis include ingestion of too much alcohol, which causes acetic acid, absorption of acetic acid, excessive loss of bicarb due to persistent diarrhea, or the accumulation of lactic acid through shock, ketosis in diabetic crisis, starvation, or kidney failure. Metabolic alkalosis is much less common than metabolic acidosis. It's indicated by the rising pH and also bicarb. So it's caused by vomiting of acid contents in the stomach or by the intake of excess base, i.e. antacids. If a blood pH is below 7, there's a depression of the central nervous system, which can cause coma or death. A blood pH above 7.8 causes excitation of the nervous system, which causes the muscles to spasm or to clench and spasm, causes extreme nervousness, convulsions, and maybe ultimately a respiratory arrest. We talk about respiratory and renal compensations. If the acid-base balance is due to malfunction of the physiological buffer system, the other one compensates. For instance, the respiratory system attempts to correct metabolic acid-base imbalances, and the kidneys attempt to correct respiratory acid-base imbalances if the other one can't keep up. In metabolic acidosis, the high hydrogen levels stimulate the respiratory centers. The rate and depth of breathing is elevated, the blood pH is below 7.35, and the HCO3 level is low. As CO2 is eliminated by the respiratory system, PCO2 follows below that normal level. Respiratory compensation for metabolic alkalosis is revealed by slow, shallow breathing, allowing CO2 to accumulate in the blood, the higher pH of 7.45, and causes an elevated CO3 bicarb, HCO3 bicarb. Renal compensation, or metabolic response. Hypoventilation causes an elevated PCO2 in respiratory acidosis. The renal compensation is indicated by high HCO3 levels. Respiratory alkalosis exhibits a low PCO2 and a high pH. The renal compensation is indicated by decreasing the HCO3 levels, bicarb levels in the blood. Hypoventilation just did that. Okay, let's go. All right. So what we've talked about here is we talked about really how the renal system helps to compensate for the respiratory system and vice versa. So we've just gone through the fluid, electrolyte, and acid-base balance of the body. This is chapter 25, and this is a lecture for, again, this is a completion of the lecture. Thank you very much.